What investigations should be undertaken? Screening for infection. Suitable samples to screen for infection, particularly chlamydia, trachomatis, and gonorrhea, should be taken if there is any suspicion of pelvic inflammatory disease or PID. All sexually active women with chronic pelvic pain should be offered screening for sexually transmitted infections or STI. A positive endocervical sample supports but does not prove the diagnosis of pelvic inflammatory disease. The absence of a result positive for chlamydia, trachomatis, or gonococcus does not rule out the diagnosis of pelvic inflammatory disease. If PID is suspected clinically, this condition is best managed in conjunction with genitourinary medicine physician in order that up-to-date microbiological advice and contact tracing can be arranged. Transvaginal scanning or TVS and magnetic resonance imaging or MRI. Transvaginal scanning is an appropriate investigation to identify and assess adnexal masses. Transvaginal scanning and magnetic resonance imaging are useful tests to diagnose adenomyosis. The role of magnetic resonance imaging in diagnosing small deposits of endometriosis is uncertain. A systemic review of the value of transvaginal scanning in the diagnosis of endometriosis found that endometriomas may be accurately distinguished from other adnexal masses. It is also useful in identifying structural abnormalities such as hydrosalpinges or fibroids, which may be relevant even if not the cause of the pain. Transvaginal scanning is of little value for the positive identification of other causes of chronic pelvic pain, including peritoneal endometriosis. The sensitivities of magnetic resonance imaging and transvaginal scanning for the diagnosis of adenomyosis are comparable in the best hands. While magnetic resonance imaging lacks sensitivity in the detection of endometriotic deposits, it may be useful in the assessment of palpable nodules in the pelvis or when symptoms suggest the presence of rectovaginal disease. It may also reveal rare pathology. Diagnostic laparoscopy. Diagnostic laparoscopy has been regarded in the past as the gold standard in the diagnosis of chronic pelvic pain. It may be better seen as a second-line investigation if other therapeutic interventions fail. Diagnostic laparoscopy may have a role in developing the woman's beliefs about her pain. Diagnostic laparoscopy is the only test capable of reliably diagnosing peritoneal endometriosis and adhesions. However, it carries significant risk, an estimated risk of death of approximately 1 in 10,000, and a risk of injury to bowel, bladder, or blood vessel of approximately 2.4 in 1,000, of whom 2/3 will require laparotomy. Clearly, conditions such as irritable bowel syndrome and adenomyosis are not visible at laparoscopy, but there is also a risk that some forms of endometriosis will be missed. Endometriosis is a disease with a large variety of appearances and is considered significantly underdiagnosed at laparoscopy. All suspicious areas should be biopsied. It is well known that the existing scoring systems do not correlate with severity of pain and that deeply infiltrating endometriosis, which is strongly correlated with pain, may be misinterpreted as a minimal disease. 1/3 to 1/2 of diagnostic laparoscopies will be negative, and much of the pathology identified is not necessarily the cause of pain. There may be adverse consequences of a negative laparoscopy. Many women may feel disappointed that no diagnosis has been made. This set of events may lead to disengagement with the medical process. The risks and benefits of diagnostic laparoscopy and the possibility of negative findings should be discussed before the decision is made to perform a laparoscopy. Perhaps it should be performed only when the index of suspicion of adhesive disease or endometriosis requiring surgical intervention is high. CA 125. Women reporting any of the following symptoms persistently or frequently more than 12 times per month: bloating, early satiety, pelvic pain, or urinary urgency or frequency, should have a serum CA 125 measurement taken. Particularly in women over the age of 50 years, any new irritable bowel syndrome symptoms should prompt such action. What therapeutic options are available? Women with cyclical pain should be offered a therapeutic trial using hormonal treatment for a period of 3 to 6 months before having a diagnostic laparoscopy. Women with irritable bowel syndrome should be offered a trial with antispasmodics. Women with irritable bowel syndrome should be encouraged to amend their diet to attempt to control symptoms. Women should be offered appropriate analgesia to control their pain even if no other therapeutic maneuvers are yet to be initiated. If pain is not adequately controlled, consideration should be given to referral to a pain management team or a specialist pelvic pain clinic. Ovarian suppression can be an effective treatment for cyclical pain associated with endometriosis. The effect can be achieved with a combined oral contraceptive, progestogens, danazole, or gonadotropin-releasing hormone analogs, all of which are equally effective but have differing adverse effect profiles. The levonorgestrel-releasing intrauterine system by Mirena or Bayer could also be considered even in adolescents. Non-endometriosis-related cyclical pain also appears to be well controlled by these treatments. An economic evaluation of the use of gonadotropin-releasing hormone analogs as empirical treatment for cyclical pain prior to laparoscopy demonstrated improved patient and physician satisfaction at reduced cost. Smooth muscle relaxants such as mebeverine hydrochloride are beneficial in the treatment of irritable bowel syndrome where abdominal pain is a prominent feature. The most commonly implicated foods were dairy products and grains. Regular non-steroidal anti-inflammatory drugs with or without paracetamol may be particularly useful. Compound analgesics such as codridramol may be appropriate. For the general gynecologist, it is probably unwise to prescribe opioids for regular use in women with chronic pelvic pain. Adjuvant treatments such as amitriptyline or gabapentin may be useful in the treatment of neuropathic pain. Non-pharmacological modalities such as transcutaneous nerve stimulation, acupuncture, and other complementary therapies may be helpful for some women. Dietary modifications may also relieve pain. Laparoscopic uterosacral nerve ablation or LUNA is ineffective in the management of chronic pelvic pain. Voluntary organizations such as Endometriosis UK can be an important source of information and support for some patients. Summary: chronic pelvic pain is common, affecting perhaps 1 in 6 of the adult female population. Much remains unclear about its etiology, but chronic pelvic pain should be seen as a symptom with a number of contributory factors rather than as a diagnosis in itself. As with all chronic pain, it is important to consider psychological and social factors as well as physical causes of pain. The assessment process should allow enough time for the woman to be able to tell her story. This may be therapeutic in itself. A pain diary may be helpful in tracking symptoms or activities associated with the pain. Where pain is strikingly cyclical and no abnormality is palpable at vaginal examination, a therapeutic trial of ovarian suppression may be more helpful than a diagnostic laparoscopy. Other conditions, such as irritable bowel syndrome, require specific treatment. Even if no explanation for the pain can be found initially, attempts should be made to treat the pain empirically and to develop a management plan in partnership with the woman. Appendix 1. Rome 3 Criteria for the diagnosis of irritable bowel syndrome. Continuous or recurrent abdominal pain or discomfort on at least 3 days a month in the last 3 months, with the onset at least 6 months previously, associated with at least 2 of the following: improvement with defecation, onset associated with a change in frequency of stool, onset associated with a change in the form of stool. Symptoms such as abdominal bloating and the passage of mucus are commonly present and are suggestive of irritable bowel syndrome. Extraintestinal symptoms such as lethargy, backache, urinary frequency, and dyspareuria may also occur in association with irritable bowel syndrome. Appendix 2. Red flag symptoms and signs. Bleeding per rectum. New bowel symptoms over 50 years of age. New pain after the menopause. Pelvic mass. Suicidal ideation. Excessive weight loss. Irregular vaginal bleeding over 40 years of age. And postcoital bleeding.